1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Hi, Mars. 1, 2, 3, 4, 5. Testing sound. Testing audio. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Awesome. Thank you. I'm going to mute as people start to gather. Remind me if I forget to take it off. I didn't forget last time, but there's a delay, so I'll remember that this time.
Welcome to a Cisco meeting. You are entering the meeting now. This meeting is being recorded. You are the only participant.
Muted. Welcome, welcome. Hi. Hi. What are you?
Hey everyone, thanks so much for tuning in for this month's Pediatric EMS Outreach Series. Today we have a special guest. This is Dave Weber. He's a paramedic who works with Lifelight, and he's also a mountaineer at Denali National Park for part of the year. He has a lot of experience in altitude sickness and cold-related injury, so he's going to give us a lecture today on those topics. And for those of you online, he always reminds us at the end, but there will be a couple questions to answer to get your CME certificate. For those of you in person, we will just send them out to you guys at the end. Without further ado, I'm going to have Dave come on up.
Thank you all. Good to be here. All right. Good. As she mentioned, my name's Dave Weber. For those of you online, I'm speaking to hundreds of people in the room right now. I do split my year between here with Intermountain Life Flight and then up in Alaska for the climbing season for Denali National Park. They asked me to speak today about environmental emergencies, specifically the ones that occur in the wintertime, and how those directly affect pediatric patients. Physiology is going to be the same, peds, adults, geriatric patient, but some of the, I think, telltale clues, especially the altitude sickness, can be a little bit different with little kiddos. The big three topics that we'll hit today and the current best practices for each are going to first be cold illness, which is also known as hypothermia. Probably heard of it that way. Cold injury, which is also known as frostbite. And then finally, a couple different forms of high altitude illness. The format for each of these three topics that we'll use today, first we'll just go through a basic definition of what it is and where we see it. There's typically some myths and medical treatment myths surrounding each of these topics that we'll try to dispel for you. A little bit of physiology on each three of these topics. Then I really want to spend time focusing on signs and symptoms and treatment. I'm really practical in my practice, and I think that there's a bunch of extra information oftentimes that accompanies these topics that doesn't necessarily correlate with better care of our patients. So I want to give you what you're going to see in the field. Like, what's this going to look like? What patient presentations are you going to see? And then how do you really practically take care of that? And then finally, we'll end with prevention. So I think this is twofold. Sure, if we can prevent in our patients, that's great, but also preventing these things in our EMS providers and fire personnel for times when either you're operating at altitude or when you're out in the cold for prolonged periods of time in the winter. Each of the topics will have a slide such as this. Do I need to do anything about failing to initiate? Okay, great. Moving on. Each of the slides will look like this. So along the bottom, it'll have each of those 6 categories for you, and then it'll be highlighted as to where we are. So if you doze off for a bit or space out, when you come back to, you'll know where we are by the red bar, the red highlights. You should know that maybe since your original training as an EMT, intermediate or advanced EMT or paramedic, there has been quite a bit of advancement in current best practices. There's a bunch of professional societies. Each of those produces textbooks and or journals. But there are practice guidelines, and those practice guidelines for, I think they're up to 15 different environmental ailments now, is the Wilderness Med Society or Wilderness Medicine Society that's actually based here in Salt Lake. They have terrific expert consensus guidelines on all of these topics we'll talk about today. And then, as I mentioned, they've got, I think, 12 to 13 other topics represented too on their website. They're all free. They're updated on a 5-year basis. So a bunch of them started in 2014. And so many of those have gotten 2019 or 2020 revamps to those practice or consensus guidelines that are out there. I remember when I was first being trained as a medic, I felt like a lot of the information that we got on these topics was typically like grandma tales or whatever, like so-and-so's mom told them or dad told them when they were growing up, and not necessarily based in current literature. Do I need to worry about flow? No problem. I'll just keep Xing out of stuff. So here's one thing I think that can be helpful, and I'll make as I mentioned, hundreds of people that are in the room help do this. But I want you to think when we get to each of these topics, what is your level of understanding of that? If we had all of you here today, I'd have you say, thumbs down means I know nothing about that. And a thumb in the middle here means I know something about that. Or thumbs up, I know a lot about that topic. The people that are in the room, let's see that for cold illness. So remember, this is our hypothermia. How do you feel like you know it? You got, I know this really well, I know this kinda, or I don't know this at all. All right. 84 people know it really well. So in terms of definition, again, there's some move to call this cold illness. It is just hypothermia. It's essentially when your body's ability to produce heat is overwhelmed by the ambient cold or ambient cold temperature. And so usually core temperature starts to drop. I don't want you to get caught up on the temperature windows of hypothermia. One, because we often don't have the ability to take accurate temperatures. And two, I don't think that needs to be a huge push for us when we're taking care of people in the field. You can look at it by their symptoms or the signs that we're seeing and bracket it that way. I will tell you, though, that technically hypothermia doesn't start until 95 degrees Fahrenheit. So a core temp of 95. So what's normal thermia for us? What's 96 to 100? Great. I like that answer a lot. A lot of people really like 98.6 as our perfectly center temperature. That varies a ton by individuals. But either way, if you're in that 96 to 100 window, you have to have dropped several degrees to technically get hypothermia. So when your partner in life or your kids are telling you they're hypothermic because they're a little bit cold, they're not. 95 degrees is a decent drop in that core body temp before we actually technically enter hypothermia. There we go. A couple of the myths. So one of them is the ability to warm someone or help someone warm with external heat sources. We don't get much from that. Almost all we get from external heat sources. So when we put a bear hugger on somebody, or when we put warm water bottles in somebody's armpits or groin, or when we have just hot air blowing on somebody, that does a decent job of preventing further heat loss, but it's not going to turn the corner on these people and actually warm them up. We warm ourselves up, or people warm themselves up, by one of two mechanisms: exercise metabolism or basal metabolism. That's it. We need simple sugars to burn for fuel, and we need to move around. Those are the two ways that we're going to actually warm ourselves. In the hospital setting, sure, we can put people on ECMO. We can start infusing warm fluids, but again, those are kind of drops in the bucket and things that we can't do in the pre-hospital setting. So in pre-hospital setting, we can prevent further heat loss by getting people warm and dry and also covering them up. But things like this, when you hear about like, oh, I'm out in the field and I've got this hypothermic patient with me or hypothermic tent mate, I'm going to get in a sleeping bag with them. That is not making anybody more comfortable. You're definitely not warming them back up. You, as a resource or as a rescuer, would be better utilized by making fire, getting people food, getting people in shelter, stripping them of wet clothes, things like that, and not just awkwardly laying next to someone in a sleeping bag thinking that you're warming them up, because you're not. So physiologically, I mentioned before that hypothermia or cold illness occurs when our body's ability to generate heat is overcome by typically ambient temperature. And so our body temperature starts to decline. That can also happen when we run out of those simple sugars or our body's energy source. So it is often said that shivering is the greatest means we have of warming up. Shivering is terrific. It works really well. It's like full body CrossFit for as long as you can sustain it. The only problem with shivering is what? Issues with shivering? What's that? It can be hard on the heart, but there's a bigger issue with, I told you there's two ways that we warm up. Exercise. Yeah, we run out of fuel quick. So it is an awesome means of warming yourself up. It's the best way. It's our body's last ditch effort of I'm going to full body convulse here in an effort to warm you back up, but it rips through our energy stores. And so when it does that, we can often see a decline rapidly in temp. Right. And so sometimes, because in why it's not really well understood, but they think also that it's just muscular involvement. Adults have a ton of muscle, and so we're able to shiver a little bit better and more effectively. Kids don't have that muscle mass to be able to really effectively shiver. And then also, typically energy stores can be less. And so as soon as that energy runs out and we don't have anything left to burn, we see really significant plummets in core body temp. So again, mentioned before, we tend to bracket it by mild, moderate, and severe. There are temperature ranges, core body temp ranges that are associated with each of those, but we don't want to focus on that, especially in the field. We want to look at how our patient presents and treat based off of that. So with mild hypothermia, again, that's less than 95 degrees, but just barely hypothermic medically, we tend to see what is referred to as the umbles. That's like the stumbly, mumbly, fumbly, grumbly person. They're not super enjoyable to be around at all, just cold and grumpy people. Also, they start to have some fine motor movement impairment. So maybe this person isn't able to zip their jacket up like you want them to, or to maybe even put gloves on, things like that. But they're just a grumpy, fumbly, stumbly person. One of the biggest issues with hypothermia is people are often apathetic, meaning they're not going to fix this problem themselves. You probably all deal with a cold person or two in your life. How good are they at fixing that problem? Horrible. They'll just like, I'm just going to sit here and wait for death to come. Or let someone else do it for me. Like, people are really apathetic, and that's one of the biggest issues with hypothermia. People aren't proactive. Like, I'm getting cold right now, I'm going to make it better. They just kind of pull away and just kind of sit there. No, I'm just going to sit on the snow here, or sit on my snowboard, or sit on my backpack and think that maybe that's going to make things better, and it's not. When we transition from mild hypothermia into moderate hypothermia, that's when we start to see violent shivering. This is shivering that's uncontrollable. You might have some minor shivering with mild hypothermia, but it's not full body, and it is controllable in the mild setting. When we get to moderate hypothermia, these people can't stop the shaking. These people are trembling constantly. We can also start to see at this stage of hypothermia, we start to get some altered mental status. So again, these are people whose cognition or mentation is starting to decline. And so in addition to the apathy we saw before, these people might not be able to cognitively fix their problem. And then severe hypothermia sets in. It says here that one of the telltale signs of that is that shivering has stopped. And can folks remind me what I just said would likely have caused that? Yeah, they have ripped through their stores. Remember, that shivering, especially that full body shivering, that is our body's response saying, hey, your core temp is going down. I'm throwing everything I can at this problem to try and make it better and try and fix it. When we see shivering stop, we see really quick temp decline in people. And then also, this is where before we said altered mental status, they still might be alert or awake on the APFU scale, maybe just a little disoriented. Here we start to see people in the verbal, painful, unresponsive spectrum of things. So let's go back and just look at the treatment for each of these. So mild hypothermia, as I mentioned before, the umbly, fumbly, stumbly person, and apathetic. For them, we need to change their environment. That means if they're cold, make them warm. If they're wet, make them dry. The other one, and it's a bit crude, but we often call it feeding and beating. This is what needs to happen for these people. We need to get some simple sugars in them by whatever means possible and make them move around. This should be your mental picture of what this treatment means. Remember, they're not going to do this on their own. They often need a lot of coaching and encouragement to get up and move around. In some of our scenarios, you're like, well, okay, well, we'll just drag them to the ambulance or put them in a sled and cart them that way. If there is any way that they can actually be active in this rescue or active in this transition into our pre-hospital setting or pre-hospital care, you should have them do that. But again, simple sugars. You don't ever want to give anybody in the field setting again. You don't want to give people any of those sugars if their level of responsive is diminished. We talk about, in a very wilderness scenario, rubbing sugars like pace or even some of those glucose tabs or honey, things like that, any of the goo, like endurance products, rubbing that into their mouth. In reality, all that's doing is allowing it to go down the normal esophageal pathway. We it doesn't actually get absorbed in the mouth at all, but in hopes of spreading that out, creating some saliva, they'll get some sugar in that way. If you do have access to IV, IO sugar and you've got medical direction to do it, there's some call for that. Because again, we need to get sugars in, they need to be able to burn something, and we need to get them to move around. When we move into moderate, we're going to say it's the exact same thing as before. So change their environment, feed and beat them. If they can, that's the star there. If they're able, if you can get them up, if you can get them moving, great. That's going to be the best way for them to turn the corner. If you can't, so if you got an ataxic patient or somebody whose level of response is decreased enough, then all we're going to do is insulate them. So that means get them warm and dry, and that's all we can do. What's that doing, did I say before? Is that warming them up? Just keeping them from getting colder. That's our goal here and when we get to these severe hypothermic patients. That's all we can do. We're not in the pre-hospital setting. No matter how high we blast that temp in the ambulance, no matter what we put on them, hot water bottles in groins and axilla, that's not going to happen. Or we're not going to actually fix the problem. There is some literature out there where we talk about handling these severely hypothermic patients gently. Why does that typically get recommended for these folks? What are we worried about with our really cold patients? What's that? Not frostbite. We typically worry about really irritable hearts. And so there is some data that as people get into this kind of framework, and usually these are people mid-80s or less, you've got really irritable hearts that can potentially enter a fatal rhythm if handled really aggressively. The kind of real world data on that and seeing that in a severely hypothermic patient in the pre-hospital setting is sparse. But they say, as a caveat, just like they do in ACLS, the bigger issues with these patients is if we are giving medications, we just want to be really cognizant that those things aren't circulating like we would normally want to. So if you're giving meds over and over, just like in ACLS, we're not going to pump these people full of epi, because once they are warmed or circulation is resumed, then they're going to get this slug of epi where we thought we were giving them 1 milligram at a time, and then they might actually be getting that full 3 or 4 milligrams that we put in and just wasn't circulating well. So in general, I have to tell you, you need to handle them gently. In reality, is you also need to get them out of the field, because staying there and just walking them out inch by inch isn't helping them either. Insulate them, handle them with normal patient care. And then the same thing for this transport horizontally. They say that that is preferable as we start to get this return of circulation or return of adequate circulation. This is just a picture for you to kind of have another mental image for you when we talk about keeping people warm and dry, is putting them in, getting them stripped of all wet clothing. That's a big one. People are really hesitant to do that. And even base layers, like skin, next to skin layers that are wet, can really impede our ability to warm somebody back up or keep them from losing more body heat. Get them stripped completely free of all wet clothing, whether it's wet from perspiration or from precipitation. It doesn't really matter. Once they're in this warm environment, too, we like to cover them with some plastic to act as a vapor barrier to just help hold some more of that heat in there. And so this is a typical, we'll have a sleeping bag typically on the bottom, a sleeping bag on the top, and then this kind of burrito wrap around them with a tarp or a tent that we can use that for transport. And again, all this is doing here for these moderate and severely hypothermic folks is to keep them from losing more body heat, but we're not actually rewarming. If you do put warm water bottles, people love putting the heat packs in there or like boiling hot water bottles. That is fine. Just make sure they're insulated. These people oftentimes might be a little insensitive and can't tell you that you're actually burning them. Or if they got decreased level of responsiveness and we're putting that hot water bottle right next to them, you can burn skin doing that. So just make sure you insulate anything that you put in there. Same with the hand warmers. I have often seen people, whether it's the full body blankets that you might have or the small heat packs that people use for hands and feet while skiing or recreating, those require oxygen to work. And so giving someone the job of shaking them vigorously outside of this setup to get them activated and then put them in. I've seen people a ton of times pull out these nice blankets, wave them twice and throw them in there. They never activate once we close up that system or close up that burrito wrap. So you're not going to get the heat generated that you want. So once they're activated, they'll burn or they'll keep going for a handful of hours, sometimes up to 8. But just realize you do need oxygen to initially activate Okay. Any questions on hypothermia before we push forward? Yeah. For the peds. And so essentially what we see in kids, probably what you see in kids with other issues and other ailments, is they tend that apathy piece where it might just be someone that's kind of gotten subdued or kind of gotten quiet. It's going to take or could take quite a bit of encouragement. We don't deal with a ton of kids up in Alaska, but we do deal with kind of the 8 to 10-year-old range when sometimes parents bring them onto the mountain with them. And that's often when you see it just kind of looks like a grumpy kid. And so we'll be really adamant about like, hey, let's get outside and go play, like having them build a snowman, having them get up and shovel some snow, anything we can do to just get them active and see if that is in fact the issue. Because a lot of times, just like an adult, they'll just kind of hunker in there and just be like a little grumpy, maybe whiny more than they normally are. But that's our biggest deal with kind of seeing that in kids. And it just takes play is what we find with them often results in play and candy are pretty good motivators. And we find that that's pretty useful and pretty helpful. But that apathy piece or the kind of reserved aspect we tend to see in both adults and kids. But physiologically and beyond that, no, just don't burn. I think the insulating piece is people really want to put a bunch of very hot things close to people's skin, and that's where we tend to see issues, especially with decreased level of response. Would everybody be able to hear that, or I should repeat that? Great. So the two things as we mentioned before, the body surface area difference, specifically big head, smaller body, and then the typical trend for these patient population to run out of those glucose stores a little bit quicker or quicker than a normal adult. And so make sure that if you've got them up and active, don't forget the second piece. There's the feeding and the beating, as rough as that sounds, especially with kids. You want to make sure you're putting in simple sugars and moving them around. Get them outside, get them playing, and give them sugar are the two best things we can do watching for some of those changes. When we move away from the hypothermia in particular and towards frostbite, let's talk about cold injury. Frostbite, same thing. What would we say? Thumbs. I feel really good about this. I know it somewhat. I don't know anything about frostbite. Great. Let's look at that. So again, anytime we've got freezing in the body tissues, that is frostbite, period. It comes, again, in a bunch of different strata, how we classify it, and we tend to just break it into two different classifications in the field because that's really all we can tell in the field. Probably the two worst treatments for frostbite are what we've always done or what we did as kids. One of them, when you came in from shoveling or you came in from sledding, what did you do with your cold hands as soon as you got inside? Maybe blowing on, then maybe you were a more highly specialized kid. What did the rest of us do when we got inside? I went straight to hot water, as did all of us. So that's number one bad problem. Oftentimes, because we've got lack of sensation, people don't know then if they're swinging the scale the opposite way and actually burning hands. The other is that you don't want to rub them together. Those two things we don't want to do. One, you can't tell if you're burning. Second one, on a microvascular level and on a tissue level, there are ice crystals in your body. And doing that vigorous rubbing can actually create, for lack of a better term, holes in your vasculature, leaky vessels that become problematic later. And so I know it seems like a stretch, but there is ice crystals that are sharp inside our tissues. And so you don't want to rub and you don't want to shove them either in hot water or right next to a really hot like fire or radiator, something like that, because we don't know. What they talk about is just skin-to-skin rewarming that we'll talk about. So I mentioned before, Swiss system has 4 different classifications. U.S. system typically uses 3 that correlate with the burn scales and the burn system. We in the field should just look at one of 2 classifications, and here they are. If you freeze the epidermis or the dermis, those outer 2 layers, that's superficial. Anything below that, into the subcu fat, into the muscle, or to the bone, that's deep frostbite. Superficial or deep, those are your only 2 choices. And we break that demarcation at the lower end of the dermis. So superficial frostbite. You might have heard the term frost nip, that also fits into this category. What we'll see, regardless of who it is, regardless of pigmentation, is similar here. You can see the picture on your right, no, that's your left up there. You can see how pale that guy's cheeks are in that picture. No matter what pigmentation or what color skin, your skin will be more pale than normal. So lighter skinned people, it will be lighter. Darker skinned people, it will be lighter for them. But you'll see this pale skin there that you see over there. Also in the superficial bracket or superficial category is blebs, or is fluid-filled blisters. The difference is that those blisters, when they're superficial, will be clear fluid. It'll just be serous fluid. Right? When are we going to see those blisters? Are we going to see those immediately? Are we going to be delayed? When have folks seen frostbite blisters in the past, or when have you heard that they form? After rewarming. It's going to happen after rewarming. And as soon as frostbite is rewarmed, then it has the same kind of course of treatment and course of care as burns do. Ahead of time, when it's frozen still, it looks and might feel different as you palpate, but that's also when we'll start to get blister formation. Just like in a burn, you don't get those blisters right away. It tends to be a delayed reaction there. When we move into the deep frostbite injuries, again, in the subcu fat, muscle, or bone, that's when we start to see these blood-filled blisters. So there is your demarcation. When we rewarm and we get some clear blisters, that's superficial. When we rewarm and those blisters are fluid, or the fluid that's in those blisters is blood, then we classify that as deep. One of the worst things that can happen with frostbite is what we call refreezing injury, and that's what happened on the picture on your right up there, where a person had an injury, been unresponsive in the snow, it warmed up the following day, still unresponsive, and then it refroze. Anytime we refreeze frostbite, the injury is almost always one that necessitates amputation. So you always want to protect from refreezing. I'll look at that here. So superficial and deep frostbite, doesn't matter which depth or which gradient we've achieved in those injuries. We want to thaw it and we want to protect it from refreezing. There is no sense, and one of the myths is, well, if I've got this frostbite injury and I can't keep it from refreezing, I don't start the thawing process. That is not true. As soon as you get to a patient, you want to start that rewarming and thawing process. You don't want to keep any body tissue frozen for longer than it already has been. And then the protection piece, again, protect it from refreezing is key. Ibuprofen and aloe are both thought to inhibit prostaglandin formation, which is some of the issue with frostbite over the long term. And so if you've got those available, and in my setting, in the field setting, we tend to prioritize these 2 meds, one for pain management, also that prostaglandin inhibition that we think is beneficial for these injuries. The main ones in the field for us, though, those 2, thaw and protect, thaw and protect. How do we want to actually thaw them? We talk about skin-to-skin rewarming. So I don't want to rub them together. I don't want to rub anybody else's skin. I also don't want to put them right next to a hot source or put them under hot water. What we want to do is skin-to-skin rewarming. If you've got the ability, what they often recommend is a water bath between 99 and 102 degrees Fahrenheit. In the field setting, that is very hard to titrate. 99 to 102. If you do have water available, think about you putting your finger in there. What we typically say is if you can hold your finger or you hold your hand in there for about 15 seconds, that's usually good. It's kind of on the lower end of a hot tub temp. But if you put your own hand that's not frozen in there for a patient and have to pull it out within that 15 seconds, that's too warm for them. So hospital treatment, 99 to 102 is a temp range for us. In the pre-hospital setting, skin-to-skin rewarming. Most patients are able to put their own hands next to something of their own skin that's warm. Armpits, belly, things like that. Feet, you might have to enlist help of whoever your rookie on your crew is. feet can go there. If you're a yogi, you can put your own feet on your belly. But skin and medical schools, whoever you have as a guinea pig, skin rewarming. So prognosis is much improved over before. There's been a bunch of either amputations that occurred too early or catastrophic injuries that we just really didn't know how well they were going to heal through imaging, and specifically some of the microvascular TPA or point-specific TPA. Clotting is one of the biggest issues here. So even after rewarming frostbite, those clots in those vessels have typically been what has prevented that injury from healing. And so that vessel's clotted off, and even after rewarming, we weren't getting renewed circulation in those appendages. We tend to see this obviously in all the extremities, fingers, toes, genitals, face is where we tend to see the most frostbite. But luckily for us, one of the world centers of excellence for frostbite care is the University of Utah Burn Center. They're on almost every paper. They've been pushing this TPA and some of the advanced imaging pieces here. So thankfully for us, it's here. In Alaska, when we have severe frostbite patients, we put them on a plane and fly them here. That treatment does need to occur within typically 12 to 24 hours of thaw. So when we start the thawing process, they need to be in the burn unit within 12 to 24 hours. So for us, we can barely get that done. For us, coming from Tooele or coming from somewhere in Salt Lake, you should be able to get them here within 12 to 24 hours. But there is a window on that treatment and when they are effective. But just know there has been some advancements, and the Burn Center at the U is one of the centers of excellence. Yep. When we start to thaw. So if they've started to thaw on their own, that's when it starts, or if it doesn't start until we get there. But that moment of thaw, kind of your time zero, is when we start the rewarming process. Great question. So again, prevention. This is always preventable. Take care of your hands. This is the pitch to all of our first responders out there too. This is just as easy to affect you, especially when we're in cold environments and we're just wearing our latex or our nitrile gloves. That is a place where when your hands get cold or sweaty in those gloves and you're working outside, we've seen frostbite injuries in our team where people are doing that. So what we will often do is put on our nitrile gloves or our patient exam gloves and then put normal gloves on top of that to work with patients in a cold environment. So don't sacrifice your own health and safety. Effects of significant or severe frostbite. This is another refreezing injury that happened. Catastrophic outcomes for a 21-year-old hunter. Horrible. Again, potentially could have had improved outcomes, but was kept in a hospital away from here for about 4 days before being shipped to the burn center. Again, you got that 12 to 24-hour window where maybe some progress can be made to help open up those clots, open those vessels, and renew that circulation there. But again, really poor outcomes for some of these patients, especially when we freeze, thaw, and refreeze. Almost always results in amputation. Okay, any questions on frostbite? This one for kids can be really tough. Swinging hands, swinging arms, doing exercise is the best, because if our core starts to get cold, the first thing that's going to happen is it's going to pull blood away and shunt from our extremities. And so for kids, making sure that gloves are warm and dry. Having kids put on, kids I feel like are notorious for having like snow-filled gloves and snow-filled boots. And so sticking their foot or sticking their hand back into those wet, cold boots is doing probably more worse than good. So making sure that you've got warm, dry apparel, warm, dry kind of hand, head, and footwear to put them in is the best. Mittens tend to be best, keeping all those digits close to one another. It tends to be a colder patient when we have all those digits separated into a glove. It's just not able to gain any. When you have an isolated finger here, that's preventing further heat loss, but it's not really warming things up. So whenever you can, even having a balled up fist in a glove is better than having their fingers all separated in a glove. The heat packs that are available out there can do wonders, but again, if someone has frozen or very cold tissue, they might not be able to tell you that it's actually burning. Some of those heat packs, hot water bottles, things like that can, again, burn patients just like they could on those hypothermic patients that don't have that much feeling or sensation. But again, watching hands, feet, nose, facial features, and genitals. Those are kind of the big 4 or 5 zones that we make sure that we are really diligent about keeping warm on patients and ourselves. Oh no.
Use for that urge. Blood.
No.
That
I think the leeches have left medicine. I might be mistaken, but I'm pretty sure leeches have we've replaced that with medications and other things. I might be wrong. There might be leeches used elsewhere, but nothing here in frostbite.
Well, I guess I'm scheduled. I asked.
Maybe afterwards.
Okay.
Yeah, if you don't mind.
Okay.
Great. So high altitude illness. We know this well. We know this okay. We don't know this at all. Where are we? Okay. We're doing all right. We do live at high altitude. I will tell you, if you just want a little primer every year, just watch this movie. That's all you need to know. Everything you need to know is in this amazing Hollywood gem. You will see here when we start to look at what altitude is, oftentimes people here that are either from Utah or transplants here don't think of this as altitude. High altitude, as you can see here, this is in meters, unfortunately, but high altitude technically starts about 1,500 meters or 4,000 feet. 4,000 to 5,000 feet above sea level is where we typically see the first signs of altitude sickness. This is especially true when we get up to our resort locations or up into the mountains, the Uintas, the Wasatch, all of those mountains. So we do actually live kind of here in the Salt Lake Valley at the lower end of high altitude. We often don't think of it that way, and so people often will be looking for other reasons why people are ill or not feeling well when altitude is the reason. So we can see kind of the mild form of altitude sickness at our location, 4,000 to 5,000 feet. We don't tend to see the severe forms of altitude illness until you get to 8,000 or 9,000 feet. Anybody know where a commercial airliner is typically pressurized to? 7,000 to 9,000 feet. The reason being, our bodies, especially when we're not active, are pretty good at dealing with altitude up to that elevation. No matter where you're from, you can come from Florida on the beach, fly up at 7,000 or 8,000 feet, cross-country flight, even overseas flight, and do okay. We don't tend to see that with pressurizations between 7,000 and 9,000 feet. As soon as people become active, it would be a different story. If we were required to walk on a treadmill in those Delta flights cross-country, I think we'd see a lot more sick people and a lot of people not having as much fun. So a couple of the myths surrounding altitude sickness. Living here your whole life or living in an altitude place does not prevent altitude sickness. The only people that are actually physically protected from altitude sickness are the Tibetan Plateau people. You hear like Nepalese or the high altitude Sherpas, and the Andes Plateau folks down in South America. Those are the only 2 people that have genetic modifications that prevent altitude sickness or help prevent altitude sickness. It does not matter if you've lived here for 45 years, up at Alta, you can still get altitude sick unless you're one of those 2 populations. We essentially will gain our acclimatization at a rate, we lose it at the same time. So if you ever are here for years, go on a Hawaii beach vacation and come back, when you're gone for about 10 days, 10 to 12 days, you lose 75 to 80% of your acclimatization. So when you come back here and think you feel awful and you think you're just mad that your vacation's over, you've actually lost a bunch of your acclimatization. You get about 80% acclimatized to a new place in about 10 to 12 days. You lose it at the same rate, no matter how long you've been here. So it is not just you thinking that, God, I feel awful when I get back from vacation. You are just not as acclimated to this zone, especially as you go up towards Park City and places higher than there. So physiologically, what happens? Your first response to hypoxia and the lesser barometric pressure at altitude, like we have here, is just typically bradycardia and tachycardia. You're going to breathe a little bit faster, heart's going to beat a little bit faster. After 3 to 4 days or so, we start to see some more red blood cell production so that we can actually carry more oxygen. Remember that the percent of oxygen here is still 21% in the air. Up at Park City, 21%. Up at top of Everest, 21% oxygen. The difference is essentially the concentration. So if you were to look at, say, a window of air at sea level, a window here and a window there, you're just going to see less and less molecules of that. Still, the makeup and composition is 21%, just less barometric pressure as you go higher and less essentially concentration of air, nitrogen, or oxygen and nitrogen molecules. Our body just adapts to that. I mentioned before it takes about 10 days or so to get 80%. To get 95% acclimatized to a place, we think it takes about 6 weeks. So to get that last 15% takes a long time. So you've worked quite a bit to be acclimated to here. As soon as you go up, that process starts anew. So when you go up to snow basin or up higher from here, your body's got to get used to that elevation. We can move up about 1,500 to 3,000 feet and deal with it. If you go more, so if you were to go from here and go up 3,000 feet and sleep, a handful of people would feel that. If you go up 4,000 or 5,000 feet from here and try to sleep, you would definitely feel that, because we need to essentially reacclimate to each new altitude that we go up. So we got 3 flavors of altitude sickness. In kids, this can be challenging, and if I forget to say this later, similar to the hypothermic patients, kids can't always tell you, like, I feel sick, or I feel this, or I'm having this sign or symptom. And so it's up to us as either parents or care providers to really hone in on that. Now, what I'd say for anyone not from here, anybody visiting, you should assume altitude when people feel like they've got kind of the flu or like hangover signs and symptoms. Not that the kids can report feeling hungover, but that kind of symptomology is very closely mirrored to what we see in altitude sickness. So by definition, for it to be AMS or acute mountain sickness, that's our baseline altitude sickness. We can see that at 5,000 feet or so in the minor kind of minor presentation. It will always have a headache. That is the telltale sign of altitude sickness in AMS, is a headache. They say it can be accompanied by any one or a combination of these 4. So that headache, you might be nauseous. That headache, you might not have a great appetite. You might not want to eat. You might have a headache plus fatigue, or headache plus insomnia. That insomnia is often a result of, what did I say was your first compensation or first mechanism to get used to a new altitude? What's the first thing that happens? Hypoxia, what's your body want to do? Just breathe faster and heartbeat faster. When you go to sleep, though, your normal tendency is for both of those systems to shut down a bit. It's for our breathing rate to go down, heart rate go down. So when you go to sleep at altitude, your body still thinks like, I'm going to chill out. I'm going to drop heart rate, drop respiratory rate. And then people will typically either wake up with a headache, or they'll have these really annoying, like gasping Cheyne-Stokes respirations where they're sleeping peacefully, and then their body will realize, oh no, I don't have as much oxygen. I want to take this big gasping breath. And so some people have this cyclical process that all night long, they're like, brain triggers, like, oh, not enough oxygen. And they will do that all night long, and it's horribly annoying. They'll wake up in the morning and be like, I slept really poorly. And you're like, no joke. I know. So by definition, at altitude or a new altitude, anytime you got a headache plus any of these 3 things, consider that it's AMS or consider it's altitude sickness until proven otherwise. If you don't adhere to what I'll tell you for treatment with AMS, the severe form of AMS or altitude or acute mountain sickness is high altitude cerebral edema. So after a period of time, essentially all of our vessels, especially in our brain, tend to constrict a bit. It's like, I'm not getting enough oxygen. I want to beat a little bit more. I want to bring more blood. So I'm going to constrict a bit to help force some more blood flow here into my brain. Over time, those vessels, like any vessels, after they've been under pressure for a period of time, can become leaky. And then we start to get this cerebral edema. Just like every other brain problem, our brain sign and symptom here is our level of responsiveness, our level of consciousness, and then we start to see changes in people's gait. We do, with all patients we suspect HACE or high altitude cerebral edema, we essentially do the drunk walk with them. Have them walk either toe to toe or just walk a straight line. Anybody that's ataxic at altitude, we consider high altitude cerebral edema. until we prove it otherwise, period. They might also have altered mental status, but some of the first things we see in these HASTE patients, they will normally have that history of the headache plus those other things, the AMS. They didn't treat it or didn't deal with it, and then it has progressed to this more severe form of cerebral edema, where we get ataxia and altered mental status. Now, HAPE is high altitude pulmonary edema. This is physiologically a completely different mechanism. Still has to do with altitude, still has to do with essentially the constriction of vessels or hypertension, pulmonary hypertension, where those vessels become leaky. But you don't have to have had AMS or HASTE to get HAPE. And that's one of the big misnomers. Sometimes people just get HAPE as their first ailment at altitude. What people will almost always miss is a day of excessive fatigue. They might be somebody on a trip with you. You're out skiing or snowmobiling or doing something with them. And one day they're great. The next day they're like really tired. You'll be like, normally Dave keeps up. Dave's doing fine. And this one day, either they or their partners will report they have excessive fatigue. We typically call this preclinical HAPE. If allowed to progress, then we start to see shortness of breath at rest. At altitude, everybody's short of breath. You can't even eat a bite of food without being short of breath once you get to really high altitude. But shortness of breath at rest is different. Nobody should be short of breath, even at altitude. So shortness of breath with exertion or moving around or doing things, we don't put much credence in that. But when people start to become short of breath at rest, we get nervous. After a bit of time, just like pulmonary edema from other causes, we can start to see those vessels, the pulmonary hypertension, that have now started to leak. We get fluid in the lungs. That's going to look like any fluid in the lungs. It might get a productive cough. We love to talk about pink frothy sputum. That is a late stage sign. You see pink frothy sputum, badness has occurred, and it's been occurring for a while. And so we might see that. But again, these tend to be a day at a time. So we see excessive fatigue. Maybe the next day they're starting to be short of breath at rest. And then usually either that night or the following day we see these productive cough in our patients. So how do we treat? We're going to break it into mild, this AMS, and the two severes, and how we treat those. This is pretty simple. If you feel crappy at altitude, you should not go up any further until you feel better. If you were sick, if you were hungover, if for any reason you had a headache plus any of those things, you should just hang out and not go out, not be super active, not be going up further in elevation. Acclimatize. And so what's that mean? That also doesn't mean just sitting in your tent. What I've said it now 2 or 3 times, what needs to happen for your body to acclimatize? What do we need to do? Breathe faster and beat your heart faster. And so we tell people to be lightly exercising. Don't go up in elevation, but don't sit in your tent either. So be up and moving around. You might not feel great, but the more you can force your respiratory rate up and heart rate up, the faster your body will acclimatize. Everyone can acclimatize if given enough time. Usually it takes 24 to 36 hours for a person to feel good at a new elevation at the longest. And again, you want to feel completely better before you push them up in elevation. If you ignored that recommendation and you're like, I've got a headache, I feel awful, but I'm on a time frame. We see this a lot on mountaineering trips. You see this a ton on trekking trips over in Nepal and places like that where people are on this regimented schedule and they're with a group and they're like, we got to keep going. You see it in kids, unfortunately, a ton over there because parents will be like, oh, you're tired, you feel crummy, let's put you on an animal or let's put you on someone's back and we're just going to carry you the rest of the way. So taking them to a new altitude when people can't necessarily say, like, I just feel really bad or I'm having a hard time breathing or I've got this really bad headache, which is where it becomes problematic in kids when they kind of pinpoint what's going on. High altitude cerebral edema, high altitude pulmonary edema, immediate descent. Period, full stop. Take them down. That is number one. Next thing, we do have some drugs we can give with high altitude cerebral edema. We can give dexamethasone. It's just a steroid, helps to deal with some of that fluid and swelling in the brain. And finally, oxygen can make them feel better. It doesn't fix the problem, however. It can make them feel better. And then for us, if we have inclement weather or we can't move due to a storm, either with an aircraft or on the ground, we will consider, we do have hyperbaric chambers. You might have heard of the Gamov bag, or it's essentially a portable hyperbaric chamber. Again, those are both temporary measures. We will do that when we absolutely can't move to make someone feel a little bit better, but our ultimate treatment goes back to that. We need to get them down. How far? Until they feel better, which we've typically found to be between 2,000 and 4,000 feet down. That's a big move. Like, we're taking people, that's not 2,000 or 4,000 feet. We're not dropping them off a cliff. This is miles sometimes that you have to go, but it's the only way to save someone's life. It's starting to have these cerebral effects to edema. Then we move into pulmonary edema. Again, the prime directive is right there. Get them down until they feel better. That's what needs to happen. There are some other things, so we can give them nifedipine. Anybody give nifedipine or hear about? So that's also sometimes referred to as procardia. It's a pulmonary, essentially deals with pulmonary hypertension. It helps to reduce that, essentially the clamping down of those blood vessels that are now leaking. Oxygen also can actually physically help these people. Unlike HACE, it doesn't really change the physiology at all. Here it can and can actually make things better. And then again, same reason as we would do it in HACE, we can use a hyperbaric chamber, but only temporarily. Because we're waiting for whether or something else. It's not an ultimate fix to be like, great, we're going to make you feel better, and then we're going to stay here. They're still going down. Okay. Prevention. So how do I prevent this from happening? There used to be an adage that said, climb high and sleep low. And that works. So during the daytime, they're like, okay, great. You go up to snowbird, say, and then it's good to go skiing for the day or hike up and then come back and sleep low. What they've started to push that adage towards is to say, go often. Go high and go often. So the more you expose yourself to altitude, the better your body will be acclimated. And the better your body will pick up on those clues of like, oh, here I am again in this hypobaric and hypoxic environment where my body knows what to do once I get up there. It's like, great, I need to breathe more. I need to beat the heart more. After a couple days, maybe I'll start making some red blood cells, but they say go often, go high and go often. Kind of the new adage. Again, we have no natural protection from being altitude sick. Period. No matter how long we've lived here, we have no genetic difference that will keep this from happening. But prevention is also, as soon as you start to feel these things, assume that it's altitude sickness. So many times people are like, oh, I slept really bad last night. I don't like this bed. Or I didn't have my normal type of coffee. And they want to blame it on everything but altitude sickness. And just blame it on altitude sickness. Either stay put if it's mild, like AMS or acute mountain sickness. And if it's HACE or HAPE, go down or take your friends down. Similar to hypothermia, HACE patients, often not able to help themselves. We've got to help. So, take-home points for you all. Be really diligent about investigating with a kid. Kids oftentimes just can't verbalize well and can't tell us what's going on. They're just going to maybe cry, be whiny, not feel good. Assume, hey, maybe it's hypothermia. Maybe this kid's hurt, or is sick from altitude sickness, or they're just really cold, and we need to actively correct that situation. For the EMS providers here, don't forget this. You got to protect yourself and your team before your patient. If you're getting cold, if you're getting altitude sick, if you're getting frostbite, you can't do anything to help your patient. And so make sure that you are warm and that you don't feel sick and that you aren't getting cold before you attend to others. Treat the patients. There's a ton of things, I'd say environmental, but also medical and trauma, where we love to get sucked into the textbook answers for everything. Treat what you see. I tried to give you the most simple presentations of what you will consistently see, and treat those. Don't get spun up and really focused on these like temperature windows in hypothermia. Don't get sucked into, well, Dave said you couldn't really get HAPE or HACE below 8,000 feet. Well, maybe we did. Just treat what you see. And finally, there is a bunch of evidence-based wilderness medicine now, where I think before it was pretty scant research and pretty scant knowledge on some of those things. So I think there are resources. As I mentioned before, it's WMS.org. The Wilderness Med Society is where you find all those practice guidelines. They're free. They've got lightning, snake envenomation, cold injury, pain management in the backcountry. But tons of them that are updated regularly. Again, we went through these three things. Treatments, signs and symptoms, really similar between adults and children. But with kids, we probably have to pry a little bit more and probably have to do a bit more motivating to get them to move. Do not get sucked into, especially in altitude. I've seen it time and time again where people will be like, oh, you're tired of walking because you feel bad? I'm going to put you in the backpack or the kid carrier or put you on a donkey. And then we're going to keep going uphill. And that can be the worst thing you do for a kid, not able to tell you what's the matter. That is my contact info. If you've got any questions after we leave here today, that's what I've got for you formally about hypothermia, frostbite, and altitude sickness. Do you get any questions online, or does anybody in the room have questions about those two things? Okay, no problem. Okay. 3 minutes to spare. Oh, sorry. You're supposed to know how to get your certificate.
Yeah, I'll do all that prodding. Remember that you who are watching online will need to answer a 3-question quiz to prove that you were paying such good attention. Those in the room will get their certificates automatically. So all you hundreds that are here should appreciate that. But email me. We'll get to those questions. There was a question here in the room about cold water drownings. And just a reminder that PETOS actually presented on cold water drownings as one of our very first in 2018 by Bob Bolte. He did one called The Heartwarming Pediatric Hypothermia. And that is on our archives. It's a fantastic lecture if you want to review that, because unfortunately fortunately we've got a lot of snow. We're going to have a lot of runoff. So we do have those cold water drownings ahead of us in the spring. Thank you so much, Dave. Fantastic. And please join us again for PETOS.